All right, everyone, thanks for joining us this evening. This evening's lecture will be given by Dr. Kevin Freedman, one of our sports surgeons here at Rothman Orthopedics. Dr. Freedman sees patients in our Chalfont and Bryn Mawr locations, and he has a wonderful talk tonight on cartilage restoration. If you have questions during the presentation, please feel free to enter them in the Q&A box at the bottom of the screen, and we will take time at the end to answer as many questions as we can. And please keep your questions pretty generalized, nothing too specific to yourself. But Dr. Freedman will do his best to answer as many as possible. So thanks again for joining us, and Dr. Freedman, you can take it from here.
Okay, thank you, Natalie, and thank you everybody for being here. So we're going to talk today on knee pain, the latest technology to restore your cartilage. And I'm a sports medicine orthopedic surgeon at Rothman, professor of orthopedic surgery, and I direct the Rothman Cartilage Restoration Program as well as the Bryn Mawr Hospital Cartilage Restoration Program. And I currently see patients in my practice out of Bryn Mawr and Chalfont. So again, my current practice is sports medicine, both knee and shoulder injuries, and direct these programs. And we're really the highest volume cartilage restoration program in the region. And importantly, also, I'm an active researcher on these problems and have nearly 150 publications, many of which are in the area of cartilage restoration. So as you'll see through the talk, I really try and focus on what's been proven in the science to work and potentially not work or doesn't have data. So try and use that research to guide our treatment. So what are we going to do today? We're going to do an overview of cartilage injuries, really going to focus on the knee, although some of these concepts do go to other joints. We're going to talk about the treatment options available. We're going to focus a lot on non-surgical treatment. I think a lot of people who are tuning in want to try to think about non-surgical care, but also we'll talk about some of the surgical options we have, talk a little bit about what's on the horizon, and certainly at the end, we're going to make sure that we answer questions for everybody. So we're going to go a little bit around the world of cartilage injuries. And the other thing that I think is important to understand for everybody tuning in, I think a lot of people are saying, my knee hurts and what can I do to make it better? I mean, there are really many sources of knee pain. So you have to find out from a diagnostic standpoint, is the cartilage really your problem? Because there's many different soft tissue injuries around the knee, including the muscles and the tendons. There are ligament injuries that can cause pain or instability. Sometimes the lining of the joint, the synovium, can be inflamed and cause pain. And then there's the joint surface itself, which is really what we're talking about when we're thinking about cartilage injuries. And we're going to get into much more detail about that. And arthritis really is an extension of a cartilage problem. So for just a few minutes, you're going to have to bear with me. We're going to go back to school because I want you to understand a little bit of the anatomy of what we're talking about so that you can understand that and the biology. So what is the articular cartilage, which is a lot of what we're talking about today? The articular cartilage is that smooth white lining on the end of the bone that lines all the joints. And in the knee in particular, there's a lining on the end of the femur, which is the thigh bone. There's also a lining on the top of the shin bone, the tibia, and plus there's a lining on the back of the patella, and all of that makes the framework for the cartilage surfaces in the knee. What does the articular cartilage do? It really provides a smooth gliding surface for the joints, and it should be nice and white and shiny without damage. And the image further on the right shows an area of damage that's bumpy and by not providing a smooth gliding surface can create pain. What does the articular cartilage do? It distributes load. So when you feel, stress through weight bearing, it distributes that over a larger surface area. It tries to minimize what's called peak stress, which means that you don't get the stress concentrated in one area as much, and really provides a low friction surface. So it wants to be nice and smooth and have very little friction. Now, it's also important to talk about the meniscus cartilage, which is the other type of cartilage in the knee. These are the cartilage rings on both the inside and the outside of the knee. When somebody says, "Oh, I tore my cartilage," they're generally talking about the meniscus cartilage, which are these shock absorbers on each side. And this is just an anatomical specimen of what it looks like, these cartilage C-shaped rings, which are right in the center of the knee. And this is what we see at the time of arthroscopic surgery with a perfectly normal meniscus cartilage. That's the medial meniscus, that's the lateral meniscus. And this is what it looks like when they're not torn or damaged. What's the function of the meniscus? Again, it's mostly load sharing and shock absorption. So it really works as that shock absorber in the center of the knee. It does increase the congruity to distribute that stress, and it provides some joint stability as well. We're also going to talk a little bit about arthroscopic surgery. So just so you have the background, what is that? That's used to examine and diagnose and treat joint problems. This is actually a shoulder, so we can do this in many different joints. We have fiber optic viewing instruments which project onto a TV screen, just little small incision about the size of a pencil tip. And then we're able to use instruments to treat damage within the knee or shoulder or whatever joint we're examining. So this is what a normal knee looks like when we're doing arthroscopy. First, this is a normal patella. So I'm looking up at the underside of a patella, and it's nice and white and smooth, and that's a glistening cartilage surface, completely normal without any damage. And then this is a normal meniscus. Again, that's that shock absorber, and I can use a probe to pull and prod, and there's no tearing, and that's that cartilage ring that works as a shock absorber. And then the metal probe's also going to probe the cartilage surface. So this is, again, a nice shiny white surface, which is a normal cartilage surface within the knee. So when we think about normal articular cartilage, it's really almost impossible to duplicate, despite what we're going to talk about and how we try to restore this damage. It's thin, but it's stiff to compression. A normal joint that hasn't been damaged can function for 80 years or more through much stress, including running and other sports activity, as long as it hasn't been damaged. And it also has the lowest coefficient of friction. So you guys may tune into a joint replacement lecture, and I'll talk just very briefly at the end today about joint replacement. But no matter what we think about when it comes to metal and plastic, none of it compares to that normal articular cartilage that God gave us. So the underlying fact for what we're going to talk about today is that articular cartilage doesn't heal once it's injured. So it's fine if it hasn't been injured, but then once it gets injured, unfortunately, it doesn't heal because it's avascular and there's no undifferentiated cells to stimulate healing. So this is why it creates such a problem once it is injured. And when we think about articular cartilage injury, there's really a huge spectrum of what that means. There's what's called the focal chondral defect, which is just a small area of cartilage damage on the surface. And then it ranges all the way to advanced arthritis when somebody is quote unquote bone on bone and it's completely worn down to bone on both sides of the joint, and the meniscus can be damaged. So it's really about figuring out how we treat people and where they are along this spectrum of disease. So how is articular cartilage damaged? I mean, there's a variety of ways that this happens. There's biomechanical problems. It includes everything from obesity and excess stress from weight. There's malalignment of the joint, which can occur from different congenital problems or things that develop over time or trauma. There's joint laxity that can contribute to biomechanical issues. And then muscle strength can also contribute to that. So weakness around the joint can create excess stress. There's traumatic injury. We see that with things like ACL tears or patellar dislocation or other types of traumatic injury that can be direct to the joint. Prior surgery sometimes can cause damage. And then there's just deterioration over time, essentially poor genetics, which can cause wear of the cartilage. So people always ask us is this just aging? And it's not aging in itself, because there's some people who can age without any damage to their cartilage. And then there's others who, unfortunately, at an early age can develop damage. So it really is probably more genetics that cause that deterioration rather than the pure aging process. So what are the symptoms? I mean, why are you on this call thinking, my cartilage is causing the knee pain that I have? So the number one thing I see when somebody has cartilage damage, everywhere from small areas of damage to more advanced arthritis, it's pain. I mean, it causes pain in that knee, and it can correspond to the area damage in the front or on the sides. Very commonly causes swelling or fluid in the knee. Sometimes we do see mechanical symptoms where it causes catching or locking if there's a loose piece of cartilage that's getting caught. And then there's giving way, and that's usually more a pain response. It's not giving way like when somebody tears a ligament in the knee, which can cause the knee to shift, but more because the muscles respond, and when you hit that area that hurts, it causes the knee to buckle. And then persistent effusions are really a common presentation. That means, somebody who gets persistent swelling in the knee, and especially if I see a young patient who doesn't have more advanced arthritis on x-rays, many times that's from an area of cartilage damage within the knee. So I'm going to talk a lot about all the different types of treatment options we have. And I think that underlying all of it is thinking about what's our goal? Like, what are we trying to do with this treatment? And I think for all of our, everybody listening, all my patients, it's important to think about, like, what are we trying to really achieve? I mean, the number one thing for nearly everybody is we're trying to relieve their symptoms. And many of the treatments that can be very effective are good at relieving symptoms. Now, everyone then wants to take the next step and say, well, what's going to prevent this from getting worse or prevent progression of my disease? And there's some treatments that we have that are able to do that. Some of the treatments aren't necessarily going to be as effective, and the disease is just going to undergo a natural history process. And then finally, can we reverse disease? I mean, this is kind of the holy grail that everybody wants, is to be able to reverse disease. And I mean, if I could sit on here and offer everybody who's listening a pill that was going to reverse their cartilage damage and arthritis over time, I mean, number one, I'd make a whole lot of money, and I probably wouldn't be talking to you guys. I'd probably be sailing on a yacht, because, it would be so, lucrative to have that available. But unfortunately, in many cases, we really can't reverse the disease, and we're just trying to relieve symptoms or prevent progression. But there are some surgical options that may ultimately reverse this process. So this is kind of my money slide that really talks about, a summary of everything we can do from a management standpoint. We're going to talk about all of these different things. There's pharmacologic treatments, including analgesics, anti-inflammatory medications, and nutraceuticals. There's physical modalities, exercise, bracing, weight loss. There's local pharmaceuticals, injections like steroids or hyaluronic acid, and biologic injections, which I'm sure will generate some questions. And then finally, there's surgery to try to restore or treat cartilage damage. And we're going to go through each of these things and try and talk a little bit specifically about what we can do. So first of all, when it comes to true medications, it's really about treating pain and inflammation. There's acetaminophen, Tylenol, which certainly can help with pain. Anti-inflammatory medications, everything from over-the-counter medications, Motrin, Aleve, to prescription anti-inflammatories, can really help calm down inflammation and treat symptoms. There's other pain modifiers, including central acting medications such as Ultram. There's muscle relaxants, which can help muscle spasm. There's narcotics, which certainly we've really gone away from. But when it comes to the mainstay from a medication treatment, there's acetaminophen and anti-inflammatory medications, and they can be effective. And one of the things you'll also hear me talk about is that if we can get an inflamed joint that just got aggravated, especially more recently, back to a state where it's more at like steady state and at homeostasis and not as inflamed, many times symptoms can improve without necessarily like changing the biologic status of what's happening in that joint. So that's why medications can be effective. Now, what about nutraceuticals? I mean, this really gets a lot of interest in press. I mean, there's many different nutritional supplements that have been promoted to help joint health and cartilage health. The thing to know is that they're not regulated by the FDA. So it's not, sometimes people say they're not approved by the FDA, but really they're not regulated by the FDA. So that's why there's so many different promotional products that can be available. So this morning I woke up early. I'm an early riser. I'm a surgeon. And, I just wanted to look on the GNC website. And when I quickly pull up, joint health, there's 75 products that come up just like in an instant, right? So this is what makes it so difficult for someone who's listening to say, well, should I be taking this stuff? Is it going to help? And there's everything from fish oil to vitamins to collagen to turmeric to other things to, your grandma's special potion to, spaghetti sauce. And it's really hard to know what might really be effective in terms of helping your joint. And I'll tell you that we tried to look at this scientifically, and we did a study on this. And, this was about 8 years ago, where we looked at this idea of chondroprotection and what's out there from a true data standpoint, that something may either help protect the cartilage or prevent progression and possibly reverse disease. And what I'll tell you is that when you look at all those things that are on the shelf and what really has data, and we looked at a lot of things, the only thing that really has some data is glucosamine and chondroitin sulfate. That's something that is included in many different nutritional supplements that are, promoted as joint health. What that is a constituent of normal cartilage, and it can increase glycosaminoglycan production. It may be able to enhance the production of hyaluronic acid. There's some evidence that it may be anti-inflammatory. And what I'll tell you is that it's the one product that did actually have some data in the literature that it can prevent the progression of disease. It didn't show that it reversed disease, but when it comes to prevention of progression, when you look at X-ray progression, there is some evidence that it can help. So it is the one product that I tell people, is certainly maybe worth spending their money on. That doesn't mean that I'm trying to tell people, what they should and shouldn't try. But when it comes to data, most of the other products on those shelves don't really have anything to support it. What about the physical modalities and stuff? First of all, when it comes to exercise, if a joint's particularly inflamed, we know that activity modification, lower impact activities, particularly when there's damage right on that cartilage surface, such as swimming, biking, lower impact walking, those all are beneficial activities. And there is scientific proof that keeping regular exercise to keep your joint healthy does have a benefit. So I do, certainly promote exercise, but staying away from high impact activities, particularly when things are aggravated, is worthwhile. What about formal physical therapy? I do think that this has a significant benefit. Somebody will say to me, why does it help? I mean, if I already have damage, what's it gonna do to reverse this process? And it does have significant benefits. And again, there's a lot of scientific proof of its benefit. Muscle strengthening around a joint to help imbalance. There's stretching to improve mobility. It can increase proprioception, which is knowing where your joint is in space as you're balancing. And especially a course to calm down an area that's inflamed can really return a joint to this area of homeostasis. So I do think there's significant benefit to physical therapy. There's a lot of problems that I see that seem surgical. Somebody tore this or damaged that, and we send them to physical therapy and they get a lot of benefit, and they end up not needing surgery by compensating and strengthening around it. So I do think that this can really provide a benefit for you. What about weight loss? This is always a touchy subject. I just put on here, the amount of stress that activities puts on your knee in terms of your body weight in pounds. So normal walking is about half your body weight, but stair climbing increases that to 2.5 times your body weight. Descending stairs, which will, descending stairs or decline commonly aggravates knee symptoms, and that's 3.5 times your body weight. And squatting is 7.5 times your body weight. So when you think about why lose 1 pound, this is the amount of stress that it can take off your knee. So there's no question that weight does increase the stress in joints. And patients hesitate to ask me this question because they don't really want to hear about it. And I understand, again, it's a sensitive topic, but the real answer is that weight does increase the stress across a weight-bearing joint. So certainly anything you can do from a weight loss standpoint is going to help you. What about bracing and orthotics? I mean, there's everything from elastic sleeves that can provide some proprioception or warmth for either cartilage damage or arthritis. And then there's the mechanical effects of more significant braces. There's things like a lateral heel wedge or what's called an unloader brace. If you have damage in one particular area of the knee, an unloader brace can take the stress off by putting stress onto the more normal areas. So if someone gets a brace that really pushes on the outside of the knee and their damage is on the inside, it pushes relief onto that side. So it can provide some pressure, and there's different types of unloading braces. So these can provide protection against an arthritic knee or a damage that's just related to a specific area of cartilage damage. What about injections? I mean, there's really three main categories of injections. There's cortisone, there's viscosupplementation, and then there's biologic injections. So first of all, what does cortisone do? I mean, cortisone is just a powerful anti-inflammatory. I like to tell my patients it's like putting 100 Advil right into the area that's damaged or inflamed. And it can just provide short-term relief for some patients. If you just ask an orthopedic surgeon, how long does cortisone last? I mean, the general answer is going to be 3 months. But that's not typically my goal of giving a cortisone injection, whether I'm treating a knee problem, a shoulder problem, whatever it is. I generally do it to try to alleviate inflammation so that then if we send somebody to physical therapy, by getting that joint calm down, it will allow them to restore that homeostasis to get back to steady state so that then that pain or symptoms go away. So when do we do it? If somebody really has an inflamed joint, if they can't take oral medications, if they've done pharmacologic therapy and it fails. So it really is a mainstay. I mean, if you're a professional athlete and you have an inflamed joint, I mean, you're pretty commonly getting a cortisone injection to try and calm that down for your cartilage damage. So it's a reasonable treatment for our patients. Hyaluronic acid injections are what's called viscosupplementation. We kind of lightly call these joint grease injection. It's basically adding some of the natural lubricant back to the knee by putting in some artificial synovial fluid. It essentially replaces the hyaluronin in your normal joint fluid. It's typically given in the office. 3 injections 1 week apart is typical. There are some single joint injections that we use, and this can be effective at relieving pain, and some inflammation can last 6 months or more for a lot of patients. What about biologic injections? So there's really 2 basic types. There's something called platelet-rich plasma, and then there's also quote unquote stem cells, which everybody gets excited about. Everybody wants to think about how stem cells can possibly, improve their problem, whatever it is. I will tell you that there's very little data, and we'll go over it in a minute more specifically. And there's both mesenchymal stem cells, and there's what's called adipose-derived stem cells that are coming from fat. So PRP, it's a growth factor treatment. It's derived from autologous whole blood. So basically, you get a blood draw that occurs within the office, and then you spin that down in a centrifuge to concentrate those platelets and to drive this what I call alphabet soup of growth factors. And the hope is that those, once injected into your joint, can both decrease inflammation, reduce pain, and then possibly, have a catabolic effect on growing cartilage. So how is this done? It's also done in the office. Typically, it can be 1 to 3 injections. I usually do 2 spaced out 21 days apart. It's got some good data to support that. Does it work, which is the real question? The answer is yes. It's really been shown to be effective for the treatment of arthritis. It's been shown to be better than viscosupplementation when you look at the data, and there is very good level 1 data, which is kind of our highest strength type of data. Whether or not it should be translated to smaller cartilage injuries is a little controversial, but a lot of times we translate what our data shows on osteoarthritis and use it for smaller areas of cartilage damage. But the real issue, what everybody wants to know again, is it reversing my disease? Does it cause cartilage regrowth? And really, most studies that have been done haven't shown that. And also when we do surgery and add PRP to help healing, it hasn't really been shown to be effective for the majority of surgeries. So although it's good for symptom modification, we don't really know that it's either preventing progression or reversing disease. Now, what about stem cell therapy? Again, this is something that everybody, is really interested in and wants to think is going to change the course of their treatment. There's really 2 major types, as I mentioned. There's mesenchymal-derived stem cells, which predominantly comes from bone marrow aspirate. And then there's adipose-derived stem cells, which comes from fat. There's also allogenic stem cells that come from either amniotic fluid or other areas. And these can be either isolated injections or once again can be used intraoperatively as an adjunct to treatment. So when you really look at the data on this, and there's more and more data that keeps coming out, the studies are mixed or whether or not this is really effective at all. It may cause some modest clinical improvement. It shows relatively good safety. Placebo effect is a real issue when you look at this because people are very invested in wanting this to work. And when you do something that's placebo controlled, it really doesn't seem to show anywhere near as much benefit. And most of the patients who get placebo actually show benefit on their own. So how is it done when it comes to bone marrow aspirate concentrate? We typically do this in the operating room, although it could be done in the office setting in certain circumstances. The iliac crest has kind of the highest concentration of quote unquote stem cells. We don't like to call this stem cell therapy because it's not pure stem cells. When you really, I don't want to get into a whole lecture on the FDA. If anybody's, starting to fall asleep, you'll really fall asleep if I start to talk to you about how the FDA does this. But I can tell you that the FDA does not allow stem cell treatment that undergoes significant manipulation. So when we do these type of aspirates, if you try to manipulate the cells or you use them for something different than they were initially intended, what's called homologous use, it becomes an entire different process for getting FDA approval. And that's why most of these treatments aren't really pure like stem cells. They just have some stem cells involved when you take an aspirate, but there's a lot of other cells that are also in there and they're not concentrated because if they are, again, it requires a whole different process from the FDA. But when you look at, does this work? Again, there's some studies showing pain relief for 6 months to a year. We are doing research on this. Currently at Rothman, we had a trial on adipose-derived stem cells, and we're continuing to look at this as we continue to use it for treatment. But when it comes to, again, reversing disease, which is what people really are interested in and sometimes trying to use this for, there is really pretty much no data to show that it is reversing someone's arthritis or cartilage damage. So when I look at this, and I do use these treatments, and I compare PRP and bone marrow aspirate concentrate, there's been several studies that show they have very similar pain relief profiles in terms of symptomatic control. They can be effective for up to 1 to 2 years. and there's really no convincing data on regeneration with either. So because PRP is much easier to use and there's more data and it's effective, that's typically the way I lean over trying to use any type of stem cell product the way it's available today when we talk about bone marrow aspirate concentrate. So what about surgery? I'm a surgeon. I do, I'm a high volume cartilage restoration surgeon. And so, we're going to talk for several minutes about what type of things are out there in terms of technology. And we know that symptomatic lesions tend to progress over time, so a smaller defect can become bigger. And we know that this surgery can be effective for improving symptoms when it comes to pain and function. So what is there in terms of general terms for treatment? There's palliative treatment, which is basically debriding loose cartilage and trying to relieve symptoms, although it's not doing anything to restore the surface. There's reparative techniques, which is trying to get your own body to heal this tissue. And the most common technique is marrow stimulation. And this is where a lot of research is going to try to see what can we do to get the body to better repair itself. And then there's restorative techniques, which include osteochondral grafts, which means both cartilage and bone grafts. And there's autologous chondrocyte implantation. And we'll talk about that for a few minutes as we go through the slides. So what's arthroscopic debridement? That's basically, this cleanup type palliative treatment. And if somebody has a smaller area of cartilage damage and it's catching or locking, this can be done to improve congruence and remove debris and inflammatory mediators. It can be done as a first-line treatment. Sometimes it's relatively short-term relief, but we've just done some recent studies that show that sometimes this can be an effective treatment for relieving pain, especially when you combine this with physical therapy and other modalities, can really get people symptomatic relief for an extended period of time. I mean, the most important thing to know is that this is not effective for advanced arthritis. So for those of you who may be on this call and are, bone on bone and they're trying to avoid knee replacement, and you say, why can't I just get a cleanup, a smaller surgery? And it's really been shown to not be effective in that setting. And in some cases, we can actually make people worse. So we really want to avoid it in that setting. So what about microfracture? So microfracture is essentially a surgery that's trying to get the body to fill in a defect with what we call scar cartilage. So essentially, if somebody has an area of damage on the surface, we clean it up to make stable edges. We use these little ice picks to try to create vents in the bone. So we use this to create holes. And then when we do that, it bleeds, and that bleeding can induce fibrocartilage to fill into the defect. This can be about 80% effective in certain defects. We do know that there are certain times when it's not as effective for bigger areas of damage. Certain areas like the patella doesn't work well. And we also know that the results from this tend to deteriorate over time. So about 4 years after, many times symptoms return. Well, there's a lot of techniques that are being considered what we call microfracture plus, and this is where the biology comes in. So we perform a microfracture, and then we're trying to figure out, well, how do we add better biology? How do we either make that scar cartilage, fibrocartilage, become more normal articular cartilage? And that includes injections. Sometimes we add something called extracellular matrix from cartilage to try to get this to work. So we're trying to do all these things to improve the repair tissue. But I will tell you, again, the science isn't quite there to make this as effective, certainly, as some of the other treatments we have, but we continue to evolve this science. There's osteochondral grafts, which, osteo means bone, chondral is the cartilage surface. So we're trying to create grafts that replace both cartilage and the underlying bone, which can commonly be the source of pain, to try to alleviate symptoms and really restore a surface. And in some cases, especially if damage is a smaller area, we can restore this back to a normal surface if it heals. So osteochondral autografts is taking a piece of cartilage from one area of the knee and moving it to another. There are times that this can make sense if somebody has damage right on the central weight-bearing area, and you can take it from an area that sees less stress. It's generally only effective in smaller defects, although some people will use multiple plugs to fill an area in something what's called a mosaic plasty. The problem we like to say is that this is robbing Peter to pay Paul, because you are taking it from a certain area of the knee, which may see less stress and weight bearing, but it still can create damage sometimes when you remove it. So that's why we typically only like to do this for a small defect, because otherwise you start removing bigger areas of cartilage and create damage from what's called the donor site, or the area that you take it from. So then there's osteochondral allografts. This is a cadaver plug of cartilage. So this is a composite graft, again, composed of fresh, normal articular cartilage from a cadaver. It's stored, it's tested, and typically has to be implanted within 28 days for the cells to be viable. And this can be a very effective treatment for treating areas of cartilage damage. So these are just a couple of different type of sample cases. This is a young patient. Sorry if somebody doesn't like blood or gore, or is eating their dinner right now. But this is a damage to the patella as well as all along the condyle. And this is a fresh condyle kind of shown on the side with a patella and a condyle that can be used to restore these surfaces. This was combined with something called an osteotomy, which is designed to unload those areas. So it's a big operation, but it can completely restore these damaged cartilage areas. This is also something called a biouni, which is a technique that can be used for an oblong defect, where we essentially replace this bigger area of cartilage damage. And we like to call it a biouni because we do unicompartmental knee replacements with metal, and this is doing it biologically. So again, this can be very effective sometimes in older patients who have an isolated area damage, and we can resurface it. So these can have 85 to 90% good to excellent results. Again, it's a composite graft that heals and replaces normal articular cartilage. So unlike the cell-based therapy where we have to get cartilage to grow, this starts out as normal cartilage. It's got normal architecture, so it can work very well, but it can be expensive. There's availability of grafts, which can be an issue. We hear about athletes that fly over to Europe and do all these certain crazy treatments sometimes. We just heard CMC's going over there for his Achilles. But one thing we have that Europe doesn't have is these osteochondral allografts, because this is really only something we do in the United States. So it's a great program to allow donors to contribute cartilage. And then there's autologous chondrocyte implantation, or ACI. And this is a technology that's really been evolving over 25 years. The initial technology involved, part of it still occurs this way. You take a piece of cartilage out of the knee, we send it up to a lab up in Boston where they mince and culture this cartilage. And then we used to inject it as liquid under a patch that was sewn in the area of the defect. This has undergone a second and third generation evolution. It used to be a little more difficult to do, and it's gotten a lot easier. So this is an example of doing an autologous chondrocyte implantation in somebody who has damage to both the patella and what's called the trochlea. And we sew a patch on, and then you glue it and inject the cartilage underneath the patch. Well, we're now up to the third generation on what's called MACI. And MACI is really all that's available now in terms of autologous cells in the United States. And this got FDA approved in 2017. And these are autologous cells that are then grown on a collagen membrane. We prepare this and then glue the membrane in place. It's a little easier. It's technically not as difficult as what I used to do. And again, this is a similar case, but this is now a MACI implant where the cells are impregnated on the membrane. It can just get glued in place. We just may have to put a couple of sutures to help hold it. And this, again, can grow into normal articular cartilage. And the most exciting thing, just really about a month ago, MACI Arthro was approved. So this was a modification to the FDA, where we can do this arthroscopically to implant the grafts. Rothman's actually going to be one of the first sites doing this. It's only for certain defects. So again, calm down if you're in the audience and you're like, wow, I can get this done arthroscopically. This is going to be an evolution, and there's only smaller defects that we can treat this way right now, but we can do it arthroscopically through relatively small incisions at this point. What are the results? Again, this can be 90% good to excellent results in the right patient. We like to say it's articular-like cartilage, unlike the fiber cartilage that occurs from microfracture, because it does grow into relatively normal cartilage. It can be durable and last over time, but it is a prolonged recovery. It's about 9 months full return to activity, really 18 months for the cartilage to mature if you look at the biology. And it is expensive for insurance, but we do this in the right patients and can have a very high success rate. One other thing I just wanted to touch on, what if I had my meniscus removed and have pain? What happens? Well, most people do well when they have meniscus surgery, but over time, we know that people can develop arthritis or pain from increased contact pressure. So when somebody has what's called meniscal deficiency, which means they have pain from missing that shock absorber, and hopefully if they haven't developed arthritis yet but have pain, we can do what's called a meniscus transplant. So a meniscus transplant is taking a cadaver meniscus. These are frozen, and these can be placed arthroscopically and then repaired in place. Again, it can take 6 to 9 months for a full return to activity. There are times when I'm doing a combination surgery with a meniscus transplant plus either an osteochondral allograft or a MACI to restore the surface. But this can also be a successful operation to replace a meniscus. So again, about 80% patients with good to excellent pain relief, but they do have to be the correct patient to get a cadaver meniscus transplant. We get asked commonly, well, aren't there meniscus substitutes that work? I mean, we've tried these things. We haven't found the right combination that works. We've looked at synthetic meniscus. There's something called a collagen meniscus implant that was FDA approved to replace a segment of meniscus, but really none of these have really proven over time to work well. So we're still working on the science to get this to work. And, for now, a cadaver meniscus is the best substitute. Are we going to be doing biologic total knees? It's hard to know. I mean, we keep advancing this technology. I mean, this is someone with some pretty significant damage. In younger patients, we're doing cartilage transplants to try to replace these areas. And it may be that, we're not doing metal and plastic anymore. Maybe I can put my partners out of business and we can do this all biologically, but we're not quite there yet, even though everybody wants us to advance this science. What are some emerging technologies? I mean, there's many examples. I mean, this is something that's been recently FDA approved called Cartilage, which is an aragonite scaffold. That means it's made out of coral, and it has a bony area and then a cartilage area that's designed to try to be a scaffold to tell the body how to heal itself. And this has shown some reasonable success in areas of mild to moderate arthritis. And again, it's an emerging technology, but we don't quite have the data the same way we have on some of the other treatments like osteochondral grafts or MACI. These are other examples. There's Cartiform, which again is trying to make some type of scaffold to heal cartilage. There's De Novo, which is juvenile minced articular cartilage, which is taking basically pediatric cartilage and mincing it up into little chiclets and trying to use that as a scaffold to grow. And although there's some data that these things can work, again, it's not a perfect technology to replace cartilage. So when you hear about these surgeries, and I include this list of all the things we discussed, is this possible for me? Well, I mean, there's really a lot of factors to consider. What treatments have been tried, and I try and treat many patients with conservative treatment of all the things I mentioned. What's somebody's age? And this is more physiologic age. It's not necessarily chronologic. A lot of people, like to kind of put labels on their age, but physiologically, we have some people who are in their 70s or 80s who have well-preserved joints, and I have people in their 40s who whose joint unfortunately looks like it's 80. and that's not amenable to getting fixed. Where's the damage? Are they already bone on bone, which can be really difficult to correct? What kind of biomechanical problems are there? Because many times these have to be combined with other corrections, something called an osteotomy, where we correct malalignment, or if meniscus is missing. All these things make it more complicated. And again, I see there's, over 200 people listening. That's amazing. I'm glad. Thank you for your participation. People listening to this later. I think everybody who's listening to this that thinks about cartilage and how we fix it or treat it is saying, I don't want a knee replacement. Don't mention the words. But you really have to consider, is knee replacement a better option? Because sometimes it is. And, it can be a very successful surgery for the right patients. And in addition to doing cartilage surgery, I do knee replacement as part of my practice. And it can be the best solution in many cases sometimes. And I think there's some, misperception about what a knee replacement is. It's really a resurfacing. Some people think we just like chop the leg off right in the center and, put in something completely artificial all the way, but it's a resurfacing. So I just talked about a lot of types of biologic resurfacing, and this is a metal and plastic resurfacing. And in certain cases, it really is the best option. So what do I think is important to do now? Number one, you have to get a diagnosis. If you're listening to this and you have knee pain, but you don't really know what's wrong, I think that's very important. And there are a lot of different treatments, as you see, including non-surgical treatments that can help with pain and inflammation. And even though they may not reverse disease, they can make people symptomatically better. So I think it's important to not only get a diagnosis, but make a treatment plan. And then finally, it's about having realistic goals. Most people, their number one goal is to relieve their symptoms. Now, I do think that it's important to try to prevent progression. And I think that it's important from a scientific standpoint that we develop technologies that reverse disease. And that's, again, where like all the money is being spent. Research is trying to develop ways to reverse disease. But in certain cases, it's just unrealistic to think that you're going to, walk into my office and I'm immediately going to be able to reverse your disease and take you back to that 20-year-old knee that was undamaged, because there's only certain technologies that can do that and certain type of damage that can be reversed. So finally, like, what can I do today? Save my knee. I think, staying active, exercise is important. Weight loss helps. Limit excessive impact if you have an injured joint. So, you want to protect it. If you have a tire that already has some damage and, you don't want to ride it over potholes all day, we want to try to protect it from sustaining further damage. Nutritional supplements and injections can provide some benefit, particularly with symptoms, but whether or not they're really reversing disease, again, even these biologic treatments that get promoted, we don't really know that it's having an effect on reversing disease. But look, stay tuned, because over the next 10 years, I think there's going to be significant advances in our biologic technology as we continue to research this. So thank you for your attention. That's all I have formally. I know Natalie is going to try and go through some questions that we can get through. I appreciate your attention. Hopefully we kept you interested. And this is taken off my business card. This is a QR code, which I'll leave up, which, can bring you to some of the information that I have on my webpage on the Rothman website. So I think we're ready for questions. So thank you.
Thanks, Dr. Freedman. That was very informative. We have quite a few questions in here, so I'm going to try to get through most of them. The first question is about knee sleeves for reducing pain and inflammation. In particular, this person is asking about one called One Compress Bamboo. It's apparently an anti-fatigue compression sleeve. The knee sleeve has 3 precision zones designed to provide gentle pressure and promote healing in your knee. This requires 0 effort and all happens as soon as you slide the sleeve on your knee. Is that something that there's some truth behind that, or have you heard of that one?
Well, I mean, I haven't heard of that one in particular. As I mentioned, the main thing that knee sleeves can do, again, providing compression, sometimes that can help reduce swelling. it also can provide some warmth, and it can provide some benefit in proprioception, which is this ability to know where your joint is in space, and for that reason it can help. I mean, I don't know that it's providing joint healing. I mean, it's easy for a lot of claims to be made by some of these promotional products, which again don't really have data to support what they're saying. That doesn't mean that it doesn't work. I mean, I don't know why the bamboo helps. I mean, I'm not sure. I'm sure the manufacturer will tell you exactly why that helps. But I think you can try it and it can provide some symptomatic relief, but I don't know that it's going to provide any healing.
Okay, thank you. Next question. For those with mild knee osteoarthritis, what exercises are considered okay to do and what exercises are not recommended? That's a little specific, but.
Yeah, well, first of all, I really recommend, there's probably no one that is listening to this that I wouldn't recommend seeing a formal physical therapist to get a program to help their problem. Whether it's knee pain from something other than cartilage, to minor cartilage damage, to severe arthritis, because a formal program of exercises is more important than what I'm going to say generically in terms of strengthening. I mean, I do think it's important you certainly don't want to do any kind of heavy lifting. I think deep squatting typically will aggravate many types of knee pain. Knee extension exercises where the weight's at your ankle and that classic knee extension can actually aggravate a lot of knee pain, particularly knee pain that's coming from the kneecap itself. So I would avoid that. So, really it's about gentle strengthening, lighter exercise, including biking, elliptical. Those are all great exercises for it. But I would like to, give a pitch to my physical therapy colleagues and say that that's important, and I would get a formal program.
Thank you. Options for arthritis behind the kneecap for runners.
So, okay. I mean, nearly all of it depends on how much damage we're talking about behind the kneecap, but that's, patellar arthritis is a particular type of arthritis that has its own treatment program. I mean, nearly everything I mentioned in the non-surgical treatment algorithm can help with patellar arthritis. Everything from formal physical therapy, I think, makes a significant difference to try to get people, back to their activity that they like, including running. The injections can make a significant difference. Braces are tough for runners. I mean, a knee sleeve can work, but anything that's more bulky, many times doesn't, is tough to run in. And sometimes you have to tone back that activity level. And sometimes you got to find some alternative exercises. But formal physical therapy and/or injections are the things that I'd recommend the most to try to keep that patellar arthritis at bay. And there are surgeries that can help, but if I have a marathon runner who comes into me and says, my knee hurts at mile 18, I'm not going to recommend some major operation. These are generally for people who really can be debilitated from their pain at, even lower levels of function.
Thank you. A couple of questions about PRP injections, asking if they're covered by insurance, which I believe they are not, correct?
Yes, they're not covered by insurance. It's not, some people think or say it's because it's not FDA approved. It's not, it has nothing to do with FDA approval, because as long as it's used for the right purpose, it's not that they're not FDA approved, but insurance companies just aren't currently covering them. So it is an out-of-pocket expense. That could change because, as I mentioned, there is actually very good data supporting the use of PRP for arthritis. It's actually one of the indications that has its best efficacy. But that doesn't mean that I can force, Aetna, Independence Blue Cross, or anybody else to say they're going to pay for it. So for now, they're not, and for that reason, it's out of pocket.
Thank you. I've read that cortisone injections can be can be, cortisone is often the first course of treatment. Does any possible damage from the cortisone correlate to how many injections one has received? So can the cortisone injections be damaging?
So the answer overall is yes. So cortisone over an extended period of time has the potential to cause some damage to articular cartilage and or tissue. It really depends on their frequency and how many. So if somebody is 20, I'm not going to give them a constant cortisone injection to alleviate their symptoms because we do worry about that potential for cumulative damage. However, first, a occasional cortisone injection, especially to help a flare, to help get a joint back to that level of, as what I call homeostasis, can be very beneficial, especially when you combine it with things like physical therapy to improve the mechanics to calm it down. So I'm not a someone who opposes cortisone because it causes can create damage, but there is some truth that repeated cortisone injections over a long period of time have that potential. And when somebody has advanced osteoarthritis and they're at the level that they basically need a knee replacement, we don't generally worry about it because it's sort of like the horse is already out of the barn. We're trying to control your symptoms. So it at that level, it can provide some benefit.
Thank you. Couple questions about osteoarthritis and meniscus tears when they're in conjunction with each other. Treatment for that, and can you avoid a knee replacement with those two symptoms?
Well, I see many patients who have a combination of meniscus tears and arthritis. And one of the toughest things in my practice is trying to figure out, well, which is causing their pain? Is it the arthritis? Is it the meniscus? Is it both? And it can be very hard to tell. And it depends sometimes on what they're complaining of. Do they have like mechanical type catching and locking? Is it simply pain? Do they have pain and swelling? And then it comes down to what treatment they've had. And typically we'll try and treat patients like that conservatively. When you get advanced arthritis, bone on bone arthritis, by definition, as that knee grinds down, it tears the meniscus. So sometimes the meniscus tear is like a byproduct of the arthritis. So if the meniscus is potentially the primary culprit in causing pain, there are times when if someone fails conservative treatment, we do arthroscopy, we can trim out that area of meniscus that's torn, leave everything that's normal, and we can make people symptomatically better. But if somebody has advanced arthritis that's essentially bone on bone, and again, the meniscus is a byproduct, we really avoid arthroscopic surgery in those cases because many times it doesn't help or we can even make that worse. So it really it's a tough question for me to give a blanket answer because the real answer is there are times when, yes, you can avoid knee replacement for a long time by doing these other treatments. And there's times when that arthritis is severe and the meniscus is almost irrelevant to what's going on.
Thank you. This question, a couple questions about the shoulder. At the start of your presentation, you mentioned some of the options would work in the shoulder as well. Would you be able to tell us which ones would do that?
Well, it's a totally different talk, but I appreciate the question because I am a shoulder doctor. And it completely depends on what indication we're talking about because I see people with shoulder pain who have rotator cuff tears and pain associated with that. And then we've got arthritis, just like we have knee arthritis. So when it comes to arthritis, nearly everything I mentioned can be done in the shoulder. Everything from the anti-inflammatories to the nutraceuticals to the physical therapy, which really can help shoulders, to the injections. The injections, once again, in this case, things like viscosupplementation aren't FDA approved for the shoulder. So that, again, is an out-of-pocket expense, but it can be used. PRP can be used in the shoulder. And cartilage restoration can even be used in the shoulder, even though in many cases it's like off-label treatments. And then there's shoulder replacement. But I also see many people who think they have arthritis in the shoulder when it's not arthritis at all. It's really the muscles around the shoulder and the tendons, the rotator cuff, and those can also be amenable to cortisone and physical therapy. And many times tears we can make better with those conservative treatments. So, I mean, it's a tough question for me to answer in 2 minutes or less. But there's a lot of conservative treatment that can be done for shoulder problems. Yes.
Thank you. Question about ibuprofen. What are the long-term effects on the body of taking 800 milligrams of ibuprofen 3 times a day?
So over time, there's the potential for liver damage. I mean, that's why typically if people are taking it for a very extended period of time, they should be seeing their primary and getting their liver enzymes checked to make sure it's not a problem. We know that all the anti-inflammatories can cause ulcers. So if somebody gets significant GI upset or is taking it for an extended period of time, that's a potential risk. So a lot of times we're not having someone take it for the rest of their life, but many times that anti-inflammatory course, especially for some period of time, can really help calm down that acute inflammation and again get somebody back to homeostasis. So the way that I typically use anti-inflammatories when people come into me with a problem is that I try and say, okay, the anti-inflammatory, whether it's oral anti-inflammatories like ibuprofen or prescription, or cortisone, which is like a local anti-inflammatory, that's going to help the pain. But then we got to do things to like cure the problem. What can we do to cure the problem? And that's typically where the therapy comes in to help muscle imbalance and stretching. And so I try and combine treatments so that we calm down inflammation, then improve the biomechanics to get the problem to go away. And even if it's not cured, because I didn't reverse the disease, hopefully we can, get it to go away for some extended period of time.
Thank you. We have quite a few questions on here. We'll take a couple more minutes and answer a few, but we will, respect everyone's time. You guys, everyone on the call does have my email, so feel free to reach out after as well if you have any additional questions or or would like to make an appointment. But Dr. Freedman, if that's okay with you, we can answer a couple more.
Yep, we keep going.
Okay. Let's see. Okay, this one's about a Baker cyst. Is it possible to have a Baker cyst behind the knee without seeing or feeling it? I have advanced arthritis, but I'm still very athletic. I've had success with PRP, but this feels different.
It is so. For those who aren't familiar, a Baker cyst or popliteal cyst is a fluid collection in the back of the knee. That typically occurs when someone gets fluid inside the knee, either from arthritis or a tear, and then that fluid leaks into the back and causes a collection, can cause pain in the back of the knee. That's something that we treat either with, some of these modalities to just treat the underlying cause to get that arthritis to calm down. Also, if you can calm down the knee from making fluid, it'll stop putting fluid many times into the back of the knee. But sometimes those Baker cysts are treated with an aspiration of the fluid or taking the fluid out and getting a cortisone shot. It's not something that I personally do. So it's something I would refer to we have non-operative specialists that use ultrasound to find the cyst and aspirate it, and they do a great job. So I have several partners who, can do that if somebody's suffering from symptoms from a popliteal cyst. So the answer is yes, it can be a source of pain and can be seen on either MRI or ultrasound. And, we do have different treatments, including aspiration, that can be done by my partners.
Thank you. A couple questions about robotic surgery, specifically for knee replacements or is robotic surgery available for the knee in this area?
So, I don't need robotic surgery when I'm doing cartilage surgery. I mean, the way that robots are generally used are to like guide surgeons when they feel like they need guidance. Like they don't you're not like controlling it like you think of a video game or like some kind of weird thing you see in a science fiction movie. It's like sort of guiding surgeons. So there's no cartilage restoration surgery that's done by robotics. And quite honestly, it's not necessary. And it can be very difficult to create the contour that has to be done for some of these surgeries by a robot. I mean, I kind of, I call myself a little bit of a Picasso when I'm doing this because we know how to shape and get the thing to match perfectly. But certainly it's done for knee replacement. If you really look at data, although it's sort of sounds fancy. We have some group of surgeons in our practice who do high volume knee replacement who use robots, and we have a lot that don't because there really hasn't been shown to be any significant difference in outcome from using a robot. So many of us don't do it, but certainly there are robotics that can assist surgeons, particularly with knee replacement. And we do have surgeons that do it at Rothman.
Thanks, Dr. Freedman. This question's a little interesting. Compared to the time you began your career, are you seeing more severe knee symptoms now than years ago? When did your career begin? Time comparison. If you have, would you speculate on why this is?
So I I've been in practice for basically 23 years. I finished my fellowship in 2001. So it has been a long time. I think that the accumulation of types of damage that occur through sports has definitely continued to escalate. We see a lot of younger kids with athletic injuries, and then that eventually, as that grows, translates into adult problems. We also know that things like obesity and all these things have grown. So obviously that creates additional problem. I mean, I think that we've also created additional solutions. And as you create more solutions, you start to see more patients that you find, can benefit from them. So it sort of like compounds itself to have these different treatment plans that are available. So, somebody who might not have been a cartilage surgery that wasn't as fruitful or didn't work 20 years ago, we didn't have as many candidates for. And now that we've got things that are more successful, we find that we have more things that are available to people. So in some ways it's grown in that sense. But I mean, it's certainly, if you look at all these charts about arthritis and knee replacement and all these things, I mean, there are always these like crazy escalation in the population that's affected. So we know this is a growing problem as the population grows, as people live longer, all those things escalate the issue.
All right, thanks, Dr. Freedman. I did just put in the chat, we apologize if we weren't able to get to your question. But, I think for, again, sake of time, we will have to end it here. So thank you so much for joining this evening, everyone. Again, I put in the chat, please feel free to email me directly for assistance with appointments if needed. If you have a really specific question that you didn't get answered and you were hoping to, I'm sure we'll be able to get that answered for you as well. And again, thank you, Dr. Freedman, for this presentation. Was wonderful, very informative. I think everyone will leave a little more knowledgeable about this topic after this evening. So thank you so much. And again, thank you, everyone. Have a great night.
Thanks, everybody. Take care.
Bye-bye.